Dr. Lansing.
All right. Well, so I want to welcome Dr. Amy Hughes Lansing. She is a clinical psychologist at the University of Vermont. She received her bachelor's in psychobiology from the University of California and a master's in clinical psychology at the University of Utah. She then completed a pre-doctoral internship at the Warren Alpert Medical School of Brown University before receiving her Ph.D. in clinical psychology from the University of Utah. So she's done a bit of traveling around. She has extensive research experience in the area of adolescent obesity and behavioral interventions in adolescents with diabetes, with more than 30 publications and several grants, including federal funding. So I had the opportunity to meet her through a colleague, and we're working on a collaboration right now that we're really excited about. So I'm thankful she was willing to share her work with us today, and looking forward to learning more about it.
Thank you, Dr. Watson, for the welcome. And yeah, I'm going to talk about, my end point of today will be to talk about that project a bit and kind of where we're going next. But so today I'm going to talk about research that our lab has been doing over the past 5 years, really more so, focusing in on better understanding the kinds of disruption in cognitive function that happen for teens with type 1 diabetes who have suboptimal glycemic levels, and what these kind of disruptions in cognitive function might mean for how we seek to improve diabetes self-management and glycemic outcomes using behavioral health behavior change type interventions. I do not have any financial disclosures or conflicts of interest for this talk today. Pretty much all the research I'm going to talk through was all funded through NIH. So I'm a pediatric psychologist. I'm a clinical psychologist who studies health behavior change, especially in kids and families facing chronic diseases. And for the last decade plus, the majority of my research has focused on type 1 diabetes management in adolescents. And so a lot of our early work was focused on trying to predict trajectories of glycemic levels across time in teens and emerging adults who have type 1 diabetes, with a really specific focus in my work on how behavior regulation, how cognitive functions that support behavior regulation predict those trajectories, and also how the family system is involved in that process. And then more recently, my lab has really been focusing on translating that work into developing more effective and more scalable interventions to improve type 1 diabetes management in teens. And so I'm going to jump in today to a study that we did while I was at Dartmouth in kind of 2015 to 2017, a clinical trial that really launched this pathway for the next 5 years of what we've been focusing on to try and improve the efficacy of our behavioral interventions in the type 1 diabetes context. So I think this is a group that I don't need to spend much time talking about the type 1 diabetes context with. You know, as a pediatric psychologist, as a behavioral scientist, this is a chronic illness that is so interesting to study because the demands that we place on families in terms of disease management are in many ways impossible. It's hard. There's not this notion of really having perfect adherence or being able to do all of these things. And even as we have, extended the access to technology, so we've added insulin pumps and continuous glucose sensors, and we have hybrid closed loop systems to help kind of regulate insulin levels without human involvement or with less human involvement. We really still are in a place where the care that's required for type 1 diabetes presents a really, really complex behavior regulation task. And when we think from a behavioral science perspective about these kind of problems, usually we're working on problems at like one little edge of the bell curve, maybe 10% of people who are struggling with substance use after trying a substance. And, here in the type 1 diabetes context, we know that over 70% of teens fail to meet clinical guidelines for optimal glycemic levels. And that was true before ADA dropped that target goal down a little bit more for teens. And so it's really almost all of our families and teens are struggling with the demands of this task and struggling with achieving optimal glycemic levels. And, early work that I did in my doctoral training and early on in fellowship was really focused on understanding the ways in which behavior regulation and cognitive function explain some of those challenges. And this work really focused on what we might think of as more volitional, or kind of, we talk about it as self-regulation sometimes, thinking about goal-directed action. Like, how do I set a goal and work toward that goal? And if I'm good at that, if I have those executive skills, I have good impulse control, working memory, cognitive flexibility, I'm going to, data suggests that I'm going to be better at this task across both adolescence and emerging adulthood. And, that in a way was heartening, because as a behavioral scientist, we have a lot of interventions that are built to focus on just these things already from other health contexts. And so across the last, really 2 decades, there's been a lot of cognitive behavioral interventions tested that target behavior regulation in these types of cognitive function to improve diabetes management. The problem is that, data suggests that the early models, the last good thorough meta-analysis, I would say, was done in 2010, at least for teens. And we get these really small effect sizes. We're pretty good at reducing diabetes distress, reducing family conflict, doing a little bit of increase in diabetes self-management and self-care behaviors. But moving the needle on HbA1c has proven really, really challenging. That was true in 2010, and it's true now in the study results that have come out since that time, including one of our own studies that I'm going to talk a bit as this kind of launch point today. But I think even when we look at, Oregon Health Sciences has this fabulous, niche program for teens with type 1 diabetes who are on publicly funded insurance and struggling with recurrent DKAs, and it's this great wraparound tech-supported services and with case management and all these, bells and whistles, and they can reduce frequency of DKAs, but that A1C movement, it's down, but it's not down enough. And so we've got some work to do here. Cognitive behavioral interventions that are normally effective in this space are not working as well for teens with type 1 diabetes or emerging adults with type 1 diabetes. So an example I can give from our lab is we tested it was around 2015 when we started this data collection, a big, bulky health behavior change intervention for teens with type 1 diabetes who were struggling with suboptimal glycemic levels. It was about a 6-month intervention. We did this via web-delivered modalities because we were in a rural region, and it was family-based, which data suggests is really important in terms of improving diabetes management outcomes. And there were 4 components, all really drawing on the best evidence-based options we have to support this kind of behavior change in other health domains. So teens received financial incentives for glucose monitoring, so hopefully that can help increase the likelihood that they're going to do this behavior because there's an immediate reinforcer coming that's consistent, and that can help them practice this behavior more often and hopefully build some habits in this behavior. They got that across the whole 6 months. And then they received 12 sessions of cognitive behavioral and motivational enhancement therapy, which is a type of cognitive behavioral therapy that has been proven to be really helpful for teens struggling with something like substance use, which is another tricky health behavior change problem. And the teens also did 5 weeks of working memory training. So we know from past neuroimaging and cognitive studies comparing teens with and kids with and without type 1 diabetes, that especially due to DKAs, seizures, kind of challenges related to type 1 diabetes, that we do see deficits in working memory, processing speeds, and some other differences. And so really trying to target working memory and boost that skill as a part of this program. And then we also, each time the teens had a therapy session, the parents also had a parent training session where they were learning strategies for increasing and being more effective in monitoring their child's diabetes management behaviors. We know monitoring, when it isn't paired with conflict, is really helpful. And so the goal of this was to teach them how to do that monitoring in ways that teens didn't perceive so much as nagging, but also how to provide praise, how to provide reinforcers, how to set reasonable goals and problem solve. And so this is a big substantive intervention package that really puts together all of our, most common evidence-based interventions. And the graph on the right shows just our basic at 6 months, so pre-post intake, so 6 months right at the end of treatment. We saw statistically significant decreases in HbA1c in our treatment group compared to our control group, but it's a 0.5%, and yes, every percent reduction we can get in HbA1c is meaningful in terms of long-term, complications, but also we know that we need to do more work than that in terms of getting A1Cs closer to the target level. And this is an average. Some teams didn't experience those benefits. And the other, there were really two things when we finished up this trial and looked at this data in 2017, where we kind of paused and I was, thinking, one, why, we got to figure out what's going on here. Why are interventions that are much more effective than this in other health behavior change domains, even tricky ones like substance use, we aren't getting movement here. We aren't seeing the change we would expect to see when you're delivering this type of an intervention. And the second thing that is important to me is I also look at something like this and think, I could never get this in a clinic. The clinician in me is thinking this required way too much supervision, way too much therapist time. I'm not going to be able to get this scalable to different clinics and get families who need these kind of services most to have access to them, especially through pediatric endocrinology specialty centers. And so moving forward, we really were trying to tackle these two problems at the same time over the last 5 years, trying to better understand what's possibly going wrong here, why are interventions not working as well, and then also trying to, when we think about new intervention modalities, trying to design with optimizing scalability in mind, something that we think we can actually get out to clinics and would be feasible. So in that first regard, trying to figure out what maybe was happening here, that what stone hadn't we turned over that might help explain some of these ways in which our behavioral interventions are less effective in this group. And we became particularly interested in thinking more about habit formation. So most of my research leading up to this time, I mentioned, had focused on more goal-directed action. How do you hold a goal in mind and work toward this goal and something that you value as an outcome? Kind of on the opposite end of that spectrum, something we often think about from like a pop psychology perspective is habits, right? Like, how do we make something habitual so that you do it even when it maybe doesn't have high value? And when you look at existing data about how the reward valuation systems that are critical from a neural perspective for forming habits, what happens to those in the presence of recurrent hyperglycemia, there are some notable changes. So in animal models, we see that hyperglycemia is associated with impaired reward learning for complex tasks, and that some of these changes in learning are in part mediated by neuroinflammation that happens in the context of hyperglycemia and then in severe cases in DKA. And when we look at preclinical human models that don't necessarily have type 1 diabetes, but where we're manipulating glycemia, what we see is that hyperglycemia, in particular persistent hyperglycemia, induces a neurobiological state that's pretty similar to depression. So we see depleted dopamine and serotonin, we see depleted BDNF, and also hyperactivity of the HPA axis. And all of those things combined together are known to impair reward learning. And so we do see changes in sensitivity to rewards and to punishments in the context of hyperglycemia. And this is also, I think, from a clinical anecdotal perspective, some of these overlaps, almost every team that gets referred to me in my clinical work is a peds endo saying to me, I can't tell, I think they might be depressed. And they're also a teen who has persistent hyperglycemia, often with high A1Cs. And, there is an overlap in this. We know that the symptoms of hyperglycemia and depression overlap heavily. It's why we think a lot about diabetes distress and depression as separate entities. We also know that in people that are experiencing depression, that there is, we see similar changes in reward learning. So people who are depressed are less sensitive to rewards and to punishments. I'm going to let the dog out of this room. And so Across this existing work, we became really interested in better understanding what is happening in terms of reward learning in teens with type 1 diabetes, especially those that are experiencing persistent hyperglycemia. And might that be one component that could help explain why our behavioral interventions have been so much less effective in this space than in other spaces? And so we, over the last 5 years, really dove into this rabbit hole of trying to understand this better and figure out what this means for interventions. I'm going to talk through 3 primary studies, one looking at some data from the clinical trial I just talked about that was our kind of first step in asking whether or not we saw some evidence for this. Then I'm going to talk about a longitudinal study we did looking at habit formation, and then an fMRI study we did. So kind of across different modalities, how we kind of thought about solving this problem. So I'm going to share about those 3 studies, and then based on that data, talk about the interventions we're developing and what we're doing next based on that work. So before I can jump into these studies, I need to take a brief moment to mention an issue about doing work in habits. So when we talk about habits in a more kind of pop or colloquial sense, I think we all have this sense of what we're talking about, like building a habit. When we think about it from an animal perspective, we're really talking about a pure stimulus response. There's a stimulus in the environment, there's an immediate behavioral response, regardless of the value or outcome that behavior will produce, you're going to engage in it. And for a long time, we've always thought about and tried to measure and think about habits in humans in that same kind of, it's either goal-directed, and you care about the value and you're working on it in this volitional and executive way, or it's a habit, it's pure stimulus. But when you look at human data around habits, that's not actually how it pans out. These 2 systems are active at the exact same time, and it's really hard to pull apart a clean, like just pure stimulus response habit in humans. Even in a context like substance use, where we're used to hearing that word a lot, data actually suggests that it may not really be a habit formation issue. So when we're talking in the research I talk about next, you're going to hear me shift from talking about a habit to this idea of automaticity. And so in humans, right now it seems that automaticity is probably the defining feature of what makes something more or less habitual. And so automaticity is the extent to which initiating or performing a behavior is dependent on holding a goal in mind, how quickly you can perform the behavior, and how much effort or attention it requires to perform the behavior. And we view automaticity in humans along a continuum. It's not that either or, that something's a habit or it's not, but that some things are going to be more or less goal dependent, are going to be done faster and with more or less effort and attention. And the reason we care about this a lot in the diabetes context too is that, not only is the formation of automaticity or the formation of habit a really important part of a health behavior change intervention. That's all of our interventions focus on this kind of learning. But when we have behaviors that have greater automaticity, it's really important because we need that to be able to perform these behaviors persistently in really stressful or busy everyday life contexts. And if we think about the daily life of a teenager, it is filled with competing goals, academic, social, diabetes, family, it's filled with time limits, how long until there's a class, when do you get a break in school, and it's filled with a lot of stressors, right? And navigating all of these different domains of life. And so if we can have type 1 diabetes management behaviors be done with greater automaticity, then we're going to help reduce burden and make this disease easier to manage. Because when they aren't very automatic, you're going to get stuck needing to exhaust a lot of frontal executive resources to make those behaviors start going every time. The other nice thing about automaticity as a framework is that typically when we talked about habits, we could really only focus on small, simple tasks because it needed to be stimulus response, something that could really happen automatically. So much of what we do in diabetes management is not that simple, right? Planning an insulin bolus, counting your carbs, figuring out your corrections, trying to sort out what, I'm going to do physical activity next. And so I actually want to bring up my glucose a little bit, and then I want to drop my basal rate for a bit. Right? All of these things can be a bit more complex. But when we think about automaticity on a continuum, it allows us to think about all of these diabetes management tasks. It could be simple things like grabbing a low-carb snack or glancing at your CGM when you get an alert, but also those more complex examples that I gave. And in that way, with a complex task, it's all about initiation. So maybe the full task itself, once you get into the behavior chain, isn't as automatic, but you can initiate it in a more automatic way, and that'll make you more likely to do it. So we think that formation of automaticity might be really important, an important thing that happens during our behavioral interventions and how we can affect behavior change, but also that it might be impaired in teens who are experiencing hyperglycemia on a frequent basis. So the first study I want to talk about, our goal was to dive back into our clinical trial data where we had a few different cognitive performance measures, and one of them captured a component of cognitive performance that impacts the development of automaticity, and that is how quickly you process diabetes cues. So to develop automaticity, faster and low attentional effort in processing is really important. You see the cue and you're able to process it quickly, and that can help kind of support and facilitate the formation of automaticity. This was about the closest thing we could get to within the clinical trial data. And what we wanted to know is whether we saw evidence that benefits from this intervention, to the extent to which you increased your glucose checking as for when you participated in this intervention, were those benefits in part explained by the development and speeding up of diabetes cue processing. So some support that, you had to get things more automatic for this intervention to be helpful. And if you weren't getting that benefit, then the intervention may not do as much for you. So we looked at that in our clinical trial data. So we had 61 teens with type 1 diabetes who completed the behavioral tasks and glucose monitoring as a part of participation in that study, both at baseline and then 6 months later. And then we used a baseline covariate structural equation modeling to try and test whether their indirect effect of the intervention on increases in glucose monitoring could be explained in part by changes in diabetes cue processing. And so what we found there in study 1 was we did see support for this idea that the effect of assignment to the intervention arm was significantly mediated by changes in diabetes cue processing. So faster processing was associated with greater increases in glucose checking post-intervention. And this provided us at least some initial support when we looked at it to say, okay, maybe there is something to this habit piece. We know it's really critical for these interventions. And the teens who were exposed to the intervention but had smaller improvements in diabetes cue processing were also going to have smaller improvements in glucose checking. And then there were group differences. The teens who didn't get the intervention at all didn't show those changes in diabetes cue processing. So we need to get those changes as a part of the learning and a part of the benefit of the intervention. That gave us some confidence to say, yes, this is worth diving into. The animal and preclinical models say that there's something probably meaningful here. We want to understand this better. And so we sought out to do a study, a longitudinal study or prospective study where we could assess automaticity for glucose checking at one time point, and then a few months down the road, look at how that predicted diabetes self-management and glycemic levels. And so in this particular study, we used a self-reported measure of automaticity, which is one of the primary ways in other health behavior samples that we've examined this construct of automaticity. So this was in a sample of 79 teens with type 1 diabetes who did that baseline survey where they did a modified version of the self-report of behavioral automaticity index, which is a well-validated health behavior automaticity measure that you can substitute in different health behaviors. And they answered multiple questions about automaticity for glucose checking as a starting point. We've also expanded this measure now to include other initiation of more complex behaviors and eating behaviors, counting carbs, insulin dosing as well. But in this one, we focused on glucose checking. We piloted the measure and then brought a version of that into this study. And then 3 to 4 months later, teens completed a 7-day diary where they reported for 7 days on their daily diabetes management behaviors, the extent to which they engaged in those, consistent with medical recommendations. And then we also got data on their glycemic levels across those 7 days that were verified via device downloads. And when we look at this data, what we saw was that when teens perceived having greater automaticity for glucose checking, so they were perceiving that doing this task required less cognitive effort, could be done quickly, could be done without thinking, could be done fairly automatically. They reported on a daily basis engaging in more frequent diabetes management behaviors, and then also had lower daily mean blood glucose levels. So for every 1 unit increase in perceived automaticity, there was a 10 milligram per deciliter decrease, almost 11, in blood glucose levels. And across the whole range of our automaticity scale, that's about a difference from top to bottom of about 50 milligrams per deciliter. So a decent decrease in mean blood glucose levels for those with the most automaticity for this behavior to those who had the least automaticity for glucose checking. And so from study 2, we were pleased to see that, okay, at least perceptions of automaticity for diabetes management behaviors are linking out to both daily disease management and glycemic levels. And so that's consistent with what the animal model and preclinical data would suggest that we might be seeing. But we also felt like we needed more information to kind of better understand how automaticity might be developing. But also, like, are these perceptions and self-reports corroborated with objective assessments? Like, do we see overlap in these things? And so that led us to the third study, which is where we brought in a health neuroscience perspective. So measurement of automaticity, unfortunately, is challenging. A lot of work has focused on those self-report measures. But health neuroscience research has suggested that we can actually capture a neural signature of automaticity by looking at a shift in the distribution of activation when a task is performed from the frontal cortex, more executive, to more direct activation of the sensorimotor cortex. And that may be kind of a neural signature, that redistribution of activation may be that neural signature for automaticity that helps explain why, after experiencing a cue, the quicker that you go right to that sensorimotor activation to prepare to engage in that behavior, the more automatic someone might perceive that task being. And so in the scanner, we have to think about ways that we can elicit this kind of reactivity. And there is one, thankfully, very convenient way to do this. So when we watch others engage in goal-directed actions, we know that that activates a network of brain regions that is often called the mirror neuron system or the action observation network. And there's been a lot of research on this in other contexts. But this is actually the same sensorimotor network that activates when we think about automaticity. It's that same region that helps us not only emulate and understand others' behaviors, but prepare our own actions. And there have been multiple studies that have used this paradigm to try and understand automaticity and the way in which behaviors are performed. So, for example, when you put professional dancers in the scanner and have them watch dance, they show much greater body region sensorimotor activation while watching those cues compared to people who are not professional dancers. When we have people who smoke cigarettes go into the scanner and watch dynamic recordings of people smoking cigarettes, they show much greater hand and mouth activation in the sensorimotor networks compared to people who do not smoke cigarettes. And that also ties out to their craving. And then in a sample of children, we have seen that greater adiposity in children is associated with greater sensorimotor activation for mouth and hand regions of the sensorimotor networks when watching people eat highly palatable foods compared to those children who have lesser adiposity, right? So that when you're beginning to emulate and prepare that behavior when you're exposed to those stimuli, and that's linked with automaticity. So we did this same paradigm to look at sensorimotor activation in adolescents with type 1 diabetes to try and see if we saw any evidence of this neural signature of automaticity being tied to glycemic levels in those teens with type 1 diabetes. So they went into the scanner and they were able to watch different types of videos, including diabetes management videos, and then we could assess for that neural signature. So in this study, we had 40 teens with type 1 diabetes complete a functional MRI scan. We have valid data from the scans for about 33 of them. The majority of data loss is due to motion artifact. It's really tricky to get teens and kids to stay still enough in the scanner for these kind of tasks. About half our sample was pump users when we did this, and because of kind of the way Medicaid at the time was funding CGMs in the state, we had very few people on CGMs in this study. We allowed teens to come in with a range of A1Cs, so our average was 8.6, but we had some teens with optimal A1Cs and many with suboptimal. One note on this is that typically in an fMRI study to look at cognitive function in people with diabetes, you may see glycemic clamps used to just hold glucose levels completely stable. We didn't have that kind of funding or resources, and so what we did instead was we had a protocol for getting stable blood glucose levels before teens came into the scanner. And then we knew their glucose right when they went in, and then we also then reassessed glucose coming out of the scanner. The majority of our teens all were able to stay in range during their time in the scanner using that protocol. And we still include that post-scan glucose, which was the closest to the time they did this task in all of our data analyses as a covariate to account for any other error that may be occurring due to minor changes in glucose levels. For the kind of measurement we're doing in this task, it's likely not as relevant as a component as it is in some other kind of neuroimaging methods. In addition to doing this scan, we also had an A1C blood test done and pulled data off glucose monitors to get variability in blood glucose levels in the days prior to the scan and also capture frequency of blood glucose monitoring. So in the scanner, they watched video clips that depicted either type 1 diabetes management behaviors, so watching someone do a finger stick check, changing pump sites, changing CGM sites, adjusting their pump, checking their CGM, all of those kinds of things. And then we also had control videos that showed individuals performing non-diabetes and non-health related activities. And our goal was to assess individual differences in the differences between sensorimotor activation and hand and body regions during those diabetes videos compared to the control. And so each person got an individual score that was reflecting that difference metric. So it's really the extent to like how much more activation do you get in these regions when you are watching and exposed to those dynamic diabetes cues. And so this first model here is looking at the data for sensorimotor activation during that diabetes test, during the diabetes videos compared to control, and its association with HbA1c. And so what we saw is that greater sensorimotor network activation in hand and body regions during the diabetes videos was associated with having lower HbA1cs. The greater activation, lower A1Cs, you see mostly blue reflected here, which is that inverse correlation. And so we saw some support here that a neural signature of automaticity for diabetes management cues was associated with having more optimal glycemic levels. When we looked at the other indicators in the study, we saw a similar pattern of effects for lower variability in blood glucose levels in the 28 days prior to the scan. So it wasn't just having an average glucose level that was lower, but really kind of constraining some of that variability and so having fewer swings. But we didn't see this same pattern of effects happen when we looked at our behavioral data, which was just the frequency of glucose checking in the 28 days prior. And I'll touch on that a little bit. So looking at this data from the neuroimaging perspective, laying it on to the behavioral or to the self-report study we did, we were really thinking a lot about, well, what does this mean cross-sectionally? We're glad that we see some support that this neural signature of automaticity for diabetes cues does seem to be linked with glycemic levels. But this data doesn't describe if it's suboptimal glycemic levels that lead to less automaticity, or if less automaticity and challenges with behavior regulation are then leading to suboptimal glycemic levels. We think from animal and preclinical human models, as well as some of our other behavioral data we've collected, that this is probably a bidirectional effect or a cyclic effect that's transactional, but with a heavy tie to how suboptimal glycemic levels impair the formation of automaticity. And so when we look at kind of the biological evidence for how if a teen is really struggling with glucose regulation and having a lot of DKA or frequent DKA or high glucose levels, that biologically they're going to have impaired reward learning very likely that would then lead to this state of not forming automaticity or not developing this automaticity signature for diabetes management tasks. But also that presents some contextual challenges when we think about learning. We learn best and can form automaticity best when you have a consistent outcome that can be consistently reinforced. And teens who have a lot of variability in their glucose levels, they're going to really struggle to see those connections between days when they monitor their glucose more effectively, when they're bolusing insulin more effectively, that they don't see it tied as much to those outcomes because they're experiencing so much dysregulation. And we can also think about the context of adolescence with changes in insulin sensitivity across puberty, and then for humans that are menstruating, changes in insulin sensitivity relative to their menstrual cycle. That there's a lot of things that for some people may disrupt some of the prime conditions for developing automaticity. Having a consistent, being able to find that consistent pattern between a behavior you engage in and the results and kind of outcome of that behavior. And especially if hyperglycemia makes you less sensitive to the possible outcomes, to the rewards and the punishments, that may set up a situation where biologically and contextually, once we have kids with frequent DKAs and that have high A1Cs, they're going to struggle to build that automaticity, even when we deliver an intervention really focused on that. And at the same time, once you don't have automaticity, it makes it more likely that you're going to struggle to do diabetes management behaviors in adolescence. And our self-reported study, prospective study, supported that pathway as well. I think we didn't measure this well in our fMRI study. We looked at just one behavior, frequency of glucose checking, and frequency can be driven by a lot of things. It's not just automaticity. A parent could have been driving a lot of the frequency of that, or a school nurse. It may have all been very goal-driven, that a kid may be having to think about these things a lot and hold them in mind a lot. They're getting the task done, but at a significant cost. And so we needed a really different behavioral measurement model in this fMRI study, I think, to help capture some of the connections between that neural signature for automaticity and behavior in everyday life. And I think we did that much better in the self-report prospective study. So when we had wrapped up these studies, we reached a point in our lab where we felt like, we have enough data built up to support that there is a very likely pattern that fits with what we see clinically and what we've seen in our failed intervention studies. I shouldn't say failed, they have significant findings, but not as good as I want to see, that it's very likely that early disease experiences, depending on time of diagnosis, that can stretch, can often introduce different kinds of challenges with diabetes self-management. And if we think from a social determinants of health perspective, right, families have such different access to technologies, high quality healthcare, financial means to support use of these different technologies, to feel confident using insulin at the rate they need to. We think about food security, transportation insecurity, housing insecurity, and have all of those things, right, impact how people are managing diabetes. DKA at diagnosis seems to impact kind of how families experience diabetes management and the challenges with kind of variation in A1C or in daily glucose levels. And so when we take a snapshot at the teens that arrive into my clinic, oftentimes they've had a few years of challenges with diabetes self-management. They've had a few DKAs. They've had persistently high A1C for a bit, and then they're getting referred to the psychology team. And we're now trying to deliver these behavioral interventions, and they really aren't working in the ways we want to see them work. And that may well be because disease pathophysiology is impairing reward learning. It's impairing the development of automaticity. And when you can't get that habit formed, when you can't make a behavior more automatic, that then forces us into this kind of cycle of struggling with diabetes management, continuing to have more challenges with your A1C and with DKAs. And we've got to find a way to break this cycle. We need something to take this apart. And our cognitive behavioral interventions we use and focus on right now in the type 1 diabetes context, they don't do that. They don't have a component in them that is meant to break down a cycle like this. And so we can imagine an intervention where we like pull a kid into inpatient and like really squeeze in tight their glucose levels for an extended period of time and like restore reward learning and then deliver an intervention. But that would be really expensive and really hard to do. And so we were thinking a lot in our lab about what is the best path forward. What are some things we could try that might be some new ways to think about interventions focused on kind of disrupting this cycle so we can be more effective in the care that we give. So we thought a lot about and explored different candidate interventions. And what we ended on was that a combination we were most interested in testing was combining our behavior change training interventions with a physical activity intervention. And the reason we felt like this was the best next step to take was that we were interested in scalable interventions that we could potentially deliver more widely to clinics that were going to be more feasible for families to engage in and more affordable. And then we also wanted our intervention to have a component that could impact reward learning and the development of automaticity. And physical activity is kind of this unique intervention mechanism that we haven't worked on a lot in the type 1 diabetes context at all. We've thought I think we've thought more about it from the perspective of athletic performance and how do we manage that, but not from the kind of sedentary activity side. There's a few pilot studies exploring different ways to do this, but we haven't had kind of research from this angle looking at this. And so data from the SEARCH trial suggests that only 24% of teens with type 1 meet physical activity guidelines. And so we see a lot of sedentary activity in our teens with type 1 diabetes. This is actually pretty similar to teens without type 1 diabetes, so a challenge we have nationally. The other things we know are that increased physical activity is associated with lower glucose levels in people with type 1 diabetes, so that engaging in at least 30 minutes of physical activity a day seems to help bring down glucose levels and can also have impacts on insulin sensitivity. We also know that from a bunch of really good trials and data looking at cognitive development in childhood, especially some looking at prevention of ADHD, that increased physical activity is also associated with enhanced reward learning. And so in our lab, we have recently trialed and piloted both components of these interventions. So we did a small pilot study with 20 teens with type 1 diabetes of a digital scalable version of our health behavior change intervention. So we got all the content moved online so that we could deliver it through text-based means, and we use health coaches rather than therapists because they're much more accessible when teens do need a weekly check-in. We were largely focusing on feasibility and acceptability, and we found very high rate, 100% attendance at the check-ins. We needed diabetes data to get shared in this program, and so we wanted to make sure that was happening. We needed it once a week, and we were getting it on over half of study days. And the majority of our teens still showed improvements in HbA1c and daily blood glucose levels, similar to what we saw in our big full package intervention. So we were really excited to see that we could take a chunk off that big full package intervention, make it digital, and see similar benefits. Obviously, it's a small study without a control arm, so I'm not going to speak to efficacy, but we really wanted to just assess feasibility and acceptability. And then we did, so that was step one. We were pleased to see that we could get that scalable. And then step two was looking at a scalable physical activity intervention. So we happened to, during this exact same time frame, get funding from NCATS that was to test a text-based physical activity intervention for teens of higher weight. And so the initial pilot data that we collected on this scalable physical activity intervention wasn't in teens with type 1 diabetes, but teens with higher weight. And this was a 12-week intervention. Teens were provided a Fitbit and had weekly goals and incentives for meeting those goals. And they got standardized tech support daily. And we found that this particular model for increasing physical activity in teens was highly acceptable and feasible. I actually have never had teens enjoy a study I've run more than this one. They often ask to stay on once they hit their 12 weeks. But we saw increases in daily active minutes and in daily steps. I think there's some changes we can make to get that impact even bigger. But also what we saw that was really key for us in this particular pilot was that increased physical activity during the course of the intervention period was associated with enhanced reward valuation. So we saw some action on the mechanism of interest that we needed to happen in the type 1 diabetes context. And so since that time, piloting those two interventions, we have now translated this particular component of the intervention to the type 1 diabetes context. So we worked with families and community advisory studios, both parents and the teens, to kind of bring a model of this over to the type 1 diabetes context, where there hasn't been a lot of work done yet on unsupervised physical activity interventions. So we know that teens, as they increase physical activity, especially if they're doing most of it after school, they experience an increased frequency in lower in lows and hypoglycemia, especially overnight. And so we've done a lot of work with the the parents and the teens around setting small physical activity goals, giving high intensity interval type training, mixing and strength training, not focusing on a competitive component after school can help with reducing those lows. But we provide an education component and adapted pieces of this intervention over to prepare to bring it to the type 1 diabetes side. And so now we applied for and received funding from a P20 center, Cobra Center here at UVM through NIH to do a pilot, we're calling it the Activate study, of this combined behavior change training with physical activity intervention for teens with type 1 diabetes. We're doing a 2-arm RCT that has a pre-post design, and we just started enrolling. We've got our first 3 families in right now. The treatment is 12 weeks long, just like in the 2 pilot studies. That includes the web-delivered behavior change training and the physical activity incentives with text coaching, and when needed, the incentive schedule shifts a little and you get web-based coaching to support the teens who do need a little bit more support in increasing physical activity. And then the other half of the sample is just participating in care as usual. We're doing in this project just a baseline and 12-week assessment. It's a virtual assessment, so we recruit all over the U.S. in this study. We have one Vermont family in right now. I think the rest are all from other states. So we use a community-based recruitment approach. And the families do a virtual assessment that includes self-report questionnaires, computerized behavioral tasks, and biophysical measures. So we send a kit to their house that includes a dried blood spot protocol, blood pressure, weight. We have a whole system for doing this entirely virtual, which is also, we were doing virtual studies before COVID hit, but has been really convenient. COVID still slowed everything down, but has been very convenient to have a virtual model already in hand. So we are looking at these 2 components of the Activate program, the physical activity intervention and the behavior change skills training program, and their impact on those proximal outcomes, so active minutes, and then the behavior change skills that we're training. We're interested also in how this intervention might impact reward learning, automaticity, and behavior regulation, because that's really our goal here. Can we use physical activity as a tool to add on to our interventions to help break that cycle down that I talked about before? So we're going to do a lot of testing of this question. And then we're also interested in then how these improvements lead to some secondary outcomes. We'll have less power to ask some of these, but looking at changes in glycemic levels and in cardiovascular disease risk as well, because the great part about a physical activity intervention, knowing that teens with type 1 diabetes are very likely to have a lot of sedentary behavior, is that maybe we're getting more, you can get more bang for her buck. We can get these changes in reward learning and automaticity perhaps that can help with behavior regulation and glycemic levels, but perhaps also make some shifts in terms of cardiovascular disease risk that could be important for long-term as well. So I want to acknowledge all the folks who made this research possible, my lab at UVM, a lot of the sites there, my grad student, Dr. Cummings, who's now faculty at Texas Tech, was in there, grad students on my current team, Dr. Jen Todd, who's at UVM Peds Endo, and then the Vermont Center on Behavior and Health at UVM and the Center for Technology and Behavioral Health at Geisel School of Medicine at Dartmouth, who continue to support my work. And, you know, I have chucked a lot out at you in these 45 minutes, kind of this story of what we've been doing for the last 5 years, but I know Dr. Watson and I have been chatting about this and connecting on this project, so I'd be very happy to answer any kinds of questions, and just, you know, thank you so much for having me here today to present. And Dr. Watson, do you want me just to hop into the chat window?
Well, you know, that's completely fine. I opened it, but if you can see those questions that are there, that would be great.
You're good. You can. You are welcome to moderate.
Well, there might be a few people that are just listening, so I'll just share a couple of questions that are here. So the first is, how do you quantifiably correlate automaticity with cognition, memory, and depression in type 1? That's a lot.
Yeah, so this is one of the puzzles we've been working on. We have a side project where we are actually collecting a lot more data using all different kinds of measures to capture the overlap in these processes. And so one of the challenges in this type of cognition and behavior-based research is that so many of the tasks that we ask people to perform conflate these things, right? They conflate memory and processing speed and different executive skills. And so we're working on developing a more specific measurement model that will be really helpful in capturing and quantifying and kind of deconflating the ways in which all of these things are interrelated. And we're using a part of that model in the trial that I was just talking about in the Activate study. So we're capturing information about depression, about motivation, because that's a big component that fits within this, about memory and different facets of cognition. And then we use a statistical approach to residualize variables out so that we can capture a little bit cleaner picture of when you pull out the changes in depression and memory and these other pieces, what do we have left in terms of automaticity, and how does that explain some of these outcomes? So hopefully we'll have some papers coming out here in the next couple of years that will clarify some of these pieces. And from a theory perspective, we think they're all going to be overlapping, right? We think that teens who have persistent hyperglycemia overlapping with depression are going to be experiencing some of the worst deficits here, because they're taking a double hit. They're going to be really struggling in both pieces. And so, merging kind of physical activity and behavior activation models that are from the depression side of things may be an important piece of that puzzle too that we're looking at.
Thank you. So where does anxiety of not achieving glycemic control and the consequences of high hemoglobin A1C impact the state of mind and cognition of the patients?
So, I talk a lot, but I have a whole different series of talks I do. And one of them that I talk about this idea a lot of, a lot of our patients and families experience a lot of distress and burnout related to a sense of never being able to achieve more optimal glycemic levels, especially our families sitting at like 10, 11, 12, some of ours are higher. Like when they hear that 7.5, it's like, that's not even, that's like, why, like I'm not, how would I ever get there? And I think we see our teens often drift to two different places. One is going to be the more perfectionist path that's getting really anxious and really trying to engage in a lot of control behaviors to try and make this work. And we see that in parents too, right? Exerting a lot of control, trying to get a situation more organized. And then we also see people who withdraw in that sense of like, I will never be successful at this, so I'm going to withdraw and I'm going to stop putting in effort because I'm not seeing a return on the investment here. And I think both of those present with different intervention needs. How we choose to intervene looks a little bit different. And, so there are definitely substantive impacts and different ways that anxiety and depression, I think, present in how our patients are struggling with type 1 diabetes management. I think some of the things I was talking about today in terms of automaticity are going to be more a challenge for the people who withdraw than the people who go to that kind of over control place. And so we may see some of that. We're assessing both anxiety and depression and some of diabetes distress related to those things. And so we should be able to start piecing that apart of kind of which of these teens might be most in need for this type of an intervention.
Right. Is there a certain age where automaticity appears to occur more readily? So is the late teenage brain more apt for automaticity versus the early teenage brain?
Okay. So when we look outside of the diabetes context at a developmental perspective, we see that the development of automaticity in some ways is easier for little kids when we can control their environment and when we are able to control a lot of the reinforcers and consequences. It's why so many of our interventions at those younger ages focus more on that piece of the puzzle and modifying behavior by both doing skill building, but also really trying to change the environment. Adolescence presents its own challenge and really at the transition to adolescence because automaticity might actually be even harder to develop because well, you're gaining so much in frontal executive capacity. You're also experiencing changes and shifts in the density of dopamine receptors in different areas of the brain that help drive social behavior. You're seeing also a lot more, a lot more independence, and we expect that age-appropriate autonomy to introduce a lot more variability into teens' environments. And we see this in emerging adults as well. And so while their brains are in a way where they can understand the complexities of outcomes much differently than a little child can, we think that it may be a phase where actually they're particularly at high risk for, as they emerge into more independence, not developing automaticity. That if the parents have been taking care of these behaviors a lot of the ways and kind of controlling the environment, as that kind of liftoff starts to happen, especially for our teens whose parents just fully back out, which sometimes happens when they're feeling kind of burnout and getting into a lot of conflict with their child, it's going to be really actually hard to form automaticity because you don't have any of the conditions that are needed for habit formation, which is going to be really consistent reinforcement across all different environments so that neurally you can develop this pattern to expecting a certain outcome, expecting certain things to happen. So I think it's a little bit tricky. Like cognitively, there's so much more development and more expertise and more creativity and all these things that teens excel in, but they might be at a particular risk if the environment isn't right for not developing these habits. Where teens who have that nice environment get a nice smooth transition, they're going to develop that automaticity nice, and they should be able to develop it easier.
Very good, thank you. Does anybody else have a question?
So, we've been interested in cognition and diabetes in the older adults, which is different from the topic we are talking. But one of our interests, in which there is a lot of overlap in terms of some of the mechanisms, particularly what we have been interested in is the role of the microbiome. So I wanted your thoughts on that, because again, when you look at these things, you have focused on automaticity and physical activity, but diet also plays a significant role, which has an impact on the microbiome, which in turn has an impact on neuroinflammation and how the cognition and their related functions will work. So what do you think about it? It's quite complicated.
One of my current doctoral students, Nathan Hacker, who will be he's spot on fabulous student. He would be delighted to hear this question because his focus of his research in our lab right now is on dietary inflammation and nutritional quality in our teens with type 1 diabetes, and how that's impacting inflammatory processes. And so as a part of some of his work, we're actually collecting some additional data in 2 of our samples right now on inflammation. That's in collaboration with Dr. Glazer's team at UC Davis, who's been doing a lot of this work on neuroinflammation in animal and human models of DKA. And so we're collecting data on that right now. It's not the centerpiece of things that I talked about, but it's definitely on our minds. And I think that's why, at every corner we've turned in this physical activity intervention has brought us to somewhere else of like, we think this may also impact inflammation. What other components can we be looking at? And something like dietary quality and other aspects of the health status of a person's sleep is another one we're really interested in that can impact these as well. So we're collecting data in this sample on dietary quality and on inflammation as well. So hopefully we'll be able to speak to that more. It's not a huge sample, but hopefully we'll at least be able to have some insights and some rationale to get some funding to collect more data on exactly those things that have been getting looked at in other diabetes populations.
Thank you.
Right. Well, I think we're right at 5 o'clock. Thank you so much. We really appreciate you joining us and for this presentation.
Well, thank you so much. I hope everyone has a good evening.
Thanks. You too.